It's really my pleasure to introduce our speaker today. When I make my list of top scientists I've ever been associated with, she's going to be on it. Lauren Ancel Meyers is a Cooley Centennial professor at the University of Texas at Austin. She was originally hired by the Department of Integrative Biology. I suspect that Jim Bull probably was there when she was hired and probably introduced her for a few seminars there. And he says if you ever need to bribe Lauren to do anything, you should use chocolate. Good chocolate. She's picky, but chocolate. She led the effort to establish the Department of Statistics and Data Science at UT, and she has a joint appointment now in those two departments. She was trained at Stanford and Harvard Universities, and as an epidemiologist, she's been a pioneer in applying computational methods to improve outbreak detection, forecasting, and control. Her work has been nationally and internationally recognized. I'm not going to go through a complete list, but in 2004, she was named one of the top 100 global innovators under the age of 35 by MIT Technology Review. And in 2017, she received the Senator Joseph Lieberman Award for significant contributions to science. Lauren leads an interdisciplinary team of scientists, engineers, public health experts in uncovering the drivers of epidemics and building practical tools for the CDC and other global health agencies to track and mitigate viral threats. Her COVID-19 modeling consortium has been a boon to the University of Idaho. There are several of us who attend her morning briefings every day, and just to tell you how significant that is, they're at 7:30 in the morning for us, but we go every day. There are typically over somewhere between 30 and 50 people at those briefings from, all over the place. And so that has been really useful for us. In addition to her work on COVID, which she's going to tell us about today, she has worked on pandemic influenza, Ebola, HIV, and Zika. When she's not consulting with the CDC or the White House, and they don't listen, so it's not her fault, and the decision makers in Austin and other parts of Texas, she's being interviewed by the national press, teaching and overseeing online education for her kids. Yes, there is a superwoman. After a seminar today, Lauren's going to take questions, and then she's going to stick around for another hour of informal discussion. So anyone who's interested is welcome to stay on the line. So please join me in welcoming Professor Meyers as she tells us about her work modeling to mitigate the COVID-19 pandemic.
Thank you. I think that's the nicest introduction. Thank you so much, Holly. And very different in spirit to the introductions I think Jim has given me in the past, where he's actually called up my parents to dig up dirt on me before he introduces me. I think Jim was not only around when I was hired at UT, but I think he had a lot to do with the hiring of me. So thank you, Jim. And so glad to see you. And it's really been such a treat for me and such just a boon to our research efforts in the consortium to have Holly and Jennifer and a number of other folks from Idaho joining us on a daily basis and giving us great ideas and sharing their insights with us. It's really helped move our thinking and our research forward as well. So it's mutually beneficial, and we hope to continue it far beyond COVID, which will hopefully end soon. So with that, let me share my screen and take you through some slides. I'm going to give you a little bit of background, sort of augment what Holly already mentioned, but and then give you a bit of a whirlwind tour of some of the research that we have done since the beginning of the COVID pandemic. But let me start by just giving you a bit of background. So I and my research team have been modeling the spread of infectious diseases, the emergence and spread of pandemics, since I think the first model I ever built was back in 1999. And really we did a lot of work in the aftermath of the 2009 H1N1 pandemic to think about, what happened during that pandemic, which was fortunately not very severe, what challenges did we face, and where might modeling and decision support tools equip us so that if and when we do face a more severe pandemic, we'll be more prepared. And so what you see on the left, the sort of movie going on, is a simulation of a pandemic spreading through Texas. This is actually an app that we developed that you can put on your own desktop computer or laptop computer, and it allows you to simulate whatever kind of pandemic you want. Deadly, less deadly, different severity and age groups. You can implement different sorts of vaccine strategies, different antiviral strategies, school closures, see how it all plays out. One of the interesting things about this particular tool that we built, right after 2009, was that we realized in 2009, and we've sort of realized in thinking about flu for a long time, that what we see in the data we collect, what we see when we track cases or hospitalizations, isn't the full picture. And certainly we feel that very much today with COVID. And so one of the things when we built this tool back in 2009-ish, 13-ish, was we actually put what we call a surveillance layer on it, so that the user of this tool could actually experience what it would be like to see very limited data when there was something brewing underfoot, and try to make decisions based on very limited data. So a lot of what we're struggling with today, we actually knew would be a problem, going back to 2009 and even before. What you see on the right is a different version of the same model that we built so that we could deploy it in this really nice visualization lab that we have on the campus at UT. It's run by our supercomputer center, TAC, and it allows all kinds of researchers to go in and visualize their data. In this case, we developed the tool so we could actually bring in groups of public health officials, public health experts, to run them through scenarios so that they could do planning exercises. So the work that we did in Texas for a number of years laid the groundwork for models that we have more recently been developing in collaboration with and for the CDC. So in around August of 2019, so a little bit over a year ago, we started a contract with the CDC to basically replicate this kind of model on a national scale. And I'll come back to that, but I'll just say that because we were maybe 80% of the way through developing this model at a US scale when COVID started spreading, we were sort of poised to very rapidly tweak the model and analyze COVID to inform some of the sort of early decision-making and thinking around it. And in particular, the model we were developing for the CDC and the model we were developing for Texas was really built so that we could rapidly analyze what we call layered intervention strategies. What if you're trying to use vaccines at the same time as school closures, at the same time as antivirals and other measures all at once to kind of save the most lives and slow transmission? And so that's really what these are designed to help us analyze. So since COVID started spreading in the beginning of January, or since it got onto our radar in the beginning of January, we have been working for a while around the clock, but really intensely to try to respond to every single request that comes our way, where we think we can actually offer some good guidance. And early on, a lot of the requests were coming from national agencies, from the CDC. This is an excerpt from an email we got from the White House, subject line urgent modeling request, where we had like a 24-hour turnaround to tell them how many people were going to die from COVID, which, as Holly said, they didn't really pay much attention to. And then much of the modeling has been done to support decision-making, situational awareness at a local scale in Austin and across the state of Texas. And I'll give you some examples of that in a bit. We've also been trying to kind of get the word out about what the science and what the data are telling us, going on TV on a couple occasions, but also we've been fortunate to be able to work with the New York Times on a couple of occasions to help build risk maps, to help people understand what the data are and are not telling us about when and where the virus is spreading, and more recently about the risks of opening schools when the virus is still spreading widely in some communities. Sometimes when I think about all of the efforts that we are doing today and kind of going back in time, I think about them in three different bins, and they're sort of organized around the kinds of questions we're asking. One kind of question is sort of what's happening today. Where and how is the virus spreading around the world today? The second set of questions is kind of looking into the future. Where will the virus be spreading next week, next month, in the spring of 2021? And then finally, how can we best use limited resources or maybe costly measures to slow spread and save lives? And for short, I think of this as modeling to provide situational awareness, modeling for forecasting, and modeling for mitigation, modeling to help people decide how to control the spread of the virus. And I'm going to run through some examples in each of these different bins. So first, let's start with situational awareness. A lot of them, the modeling and the analysis that we've done just to provide basic understanding about this virus was really modeling we did in the very beginning, when we didn't have a good handle on what this threat was really about, when we were getting really kind of inconsistent and confusing reports out of Wuhan, China. So let's go back to like those very first weeks. And I don't know if you remember, but the very first reports, at least that I heard, were that there's this new potentially deadly virus and people are occasionally getting infected, but it's really only animal to human transmission. It's not spreading human to human. And then within a few days it was, well, now there's some evidence that there's limited transmission, but it's primarily in households, where people have very intensive contacts with each other. And then, within a week after that, it was, oh no, actually it looks like it may be spreading much more easily among people. But it was just really, really confusing what we were hearing. So what did we not know in those first few weeks? Well, we didn't know how many people were infected with the virus in Wuhan. And this is a map we made much later that estimates, this particular map is an estimate of how many kids were infected, or no, how many kids were actually hospitalized for COVID during a period of time where we had basically no information. We didn't know how fast it was spreading in Wuhan. And we didn't know if it was only spreading in Wuhan or whether it was actually already emerging in other cities around China or around the world. So one of the very first studies we did was just try to find whatever data we could find to kind of triangulate the answers to some of these questions, because the data coming directly out of Wuhan wasn't telling us what was going on. So what data did we feel like we could sort of trust a little bit more than what was coming out of Wuhan? Well, one was the first cases that were reported outside of China. So the very first cases were reported, the first 19 cases, the first one was in Bangkok, and then there was one in Seattle, and then there were a few others in the cities that you see on this map. So we sort of, even though there were probably other cases that now looking back probably had landed in other cities around the world, we at least felt that, these were kind of a good indication, of when this virus was sort of escaping out of Wuhan into the rest of the world. We also had really extensive air travel data that we've been using for a long time, and other research groups have been using for a long time, just to model the global circulation of all sorts of pathogens. And so we knew on a daily basis how many people were traveling from Wuhan to every other city in the world by air. And then we also got our hands very rapidly on some cell phone-based mobility data within China. And specifically, it was the daily number of people moving between 370 different cities in China, categorized by whether it was air travel, train travel, or car travel. And so we knew something about the flow inside of China. So using that data, again, we tried to figure out what was going on in Wuhan. And actually, before I go to that, let me just give you, I didn't include a slide with the details, but basically, here's the basic idea. We assumed that Wuhan was sort of this black box, and there was this virus that was spreading exponentially, right? It was sort of like these typical epidemic curves, but we didn't know the rate of spread, or we didn't know the doubling time of the virus in Wuhan. But what we imagine that everybody who travels out of Wuhan, it's sort of like picking somebody at random from the Wuhan population and looking, are they infected or not? And based on when we started seeing people infected and where they landed all over the world, and knowing what we know about the volume of people traveling, we could kind of, like I said earlier, sort of triangulate indirectly and for what that growth rate of the virus must have been in Wuhan at the time. So that's sort of how we approached it. And without going into more detail, I'll tell you what we found. So we found that the virus had spread much farther and much faster than the initial case reports out of Wuhan were telling us. So by the time Wuhan locked down on January 23rd, China reported a total of 425 cases. That's the black, my mouse is not working, but that's those black dots there. What our estimates suggested at the time was that the virus was doubling approximately once a week in terms of like the number of new cases, and that by the time Wuhan closed down, there were probably closer to 12,000 or 13,000 cases, that had cumulative cases in Wuhan. And then when we made projections about how much it had probably already gotten to other cities all around China, prior to that lockdown, what we estimated that there were probably well over 100 cities that already had one or more introductions and very likely had outbreaks already underway. And at that point in time, none of those outbreaks had been identified, but within a few weeks of us making these estimates, it was very clear that most of those cities indeed already had outbreaks that had stemmed from people traveling from Wuhan during that early period. So that was the first study. The second study, again, just to kind of give us situational awareness, was the most jaw-dropping study, I think, of this entire, of all the research we've done on COVID. And it was really a very simple study. And let me just set the stage for this. So this was also work we were doing at the end of January, early February, when there was little known about the virus. And at that point in time, once we realized this thing had the capability of spreading fairly easy for person to person, a lot of the folks in my world who'd been modeling, SARS and flu and all these other threats and hypothetical threats, we were sort of operating under the hope and the assumption that this virus would spread a lot like the original SARS virus in 2003, and that we would be able to mitigate it. We would be able to kind of contain clusters and prevent this thing from emerging into a global pandemic. So as you remember, SARS was a huge threat, but it never became a global pandemic. There were small, medium, large outbreaks, but never really spread that widely. And how are we able to contain them? Well, primarily through testing, contact tracing, and isolation. And why were we able to do that with SARS? Well, SARS was sort of a slow spreader. SARS was, and I'm going to introduce a term now, the serial interval of a disease is the time between a person developing symptoms and the person they infect developing symptoms. So if I get sick and I infect someone else, it's how long before I first feel sick and they first feel sick. And if you know the serial interval for a pathogen, you know something about the pace of transmission. So with the original SARS virus, that serial interval was 8 days. Okay, so I get sick, I feel sick, and if I had infected somebody, they're not going to start feeling sick for a good week after me. And the other thing about SARS was kind of slow, and the other thing about SARS was that people weren't actually infectious until they felt sick. And so there weren't people silently running around infecting other people. Once somebody felt sick, that is when they started being contagious, and you could sort of isolate them. And so we were sort of operating under the assumption and the hope that this virus would behave similarly. And the study we did was one of the first to tell us that assumption was clearly wrong for this virus. And this was really simple. We teamed up with a group of Chinese students who scraped public health websites from 18 different provinces in China, looking for case reports of people who were infected with COVID, and then there'd be like the epidemic case report. And we were looking for reports that contained a few pieces of information. It told us on what date the case started feeling symptoms. It told us who they think infected that person. And in many cases they didn't know, but for some of these cases, they could kind of, connect the dots, that this person had a spouse who had just returned from Wuhan, developed symptoms a few days before them, was sort of a smoking gun. So in cases where there was a good idea for who infected them, we also wanted to know on what day did they develop symptoms. So we found about 450 case reports that were translated into English for us, where we could roughly say the serial interval for this particular case between their infector developing symptoms and them developing symptoms was so many days. And the whole crux of the study was basically just making a histogram based on those 450 serial intervals that were reported in data. And this histogram, when we first visualized it, was really surprising and concerning. And there are three things that just jumped out right away. One was that this thing was spreading much faster than SARS-1. This thing, instead of a serial interval of 8 days, the serial interval was probably somewhere around 4 or 5 days. So spreading at about twice the pace. The really concerning thing was the small subset of negative serial intervals, which means that the person who was infected actually started feeling sick before the person who infected them. And if they connected the dots correctly, and that really was the relationship, the infector or infectee, that means that the person who did the infecting was contagious before they felt sick. Okay, and there is a lot of uncertainty in this data, but there were enough cases like this where this raised the real possibility of pre-symptomatic transmission, which we now know commonly happens. And then finally, there was this longer tail, which meant that to really make sure that people don't infect others, we probably have to isolate them for at least a couple weeks after the onset of their symptoms. So this was really concerning. And in fact, as soon as we made this histogram, we shared it with our colleagues at the CDC, and their response was immediately, you must have made a mistake. They simply didn't believe that there was pre-symptomatic transmission. There could be pre-symptomatic transmission like this. And within a few days, we went back, we checked our math, we checked our data, and things still kind of held up. And then within a few days, there was another study that came out. And in fact, somebody who told us that the Chinese government had known this for a while and was sort of sitting on that information. Third study for basic sort of early looks at what China could tell us about what was going to happen as it spread around the world was a study where we looked at the relationship between when cities implemented their first social distancing measures. And so we were looking at cities in China, and it varied from city to city. Some closed schools first, some closed restaurants first, some enacted other measures first. And so what was the relationship between how quickly they enacted their first measure and how long it took them to bring these sort of small emerging outbreaks under control? And to do this study, we looked at data from 58 different cities. This is an example of the data from one of these cities. So the top graph is just a case count through time, and the blue parts of the bars corresponds to cases that they think were imported. So somebody who arrived in the city having been infected elsewhere. And the red parts of the bars are the people who they think probably were infected locally. And so in this case, the first public intervention, social distancing intervention, happened, it looks like, I don't know, about a week after the first identified case in the city. And what you see on the bottom is an estimate for the reproduction number of the virus in the city at the time based on those case data. The reproduction number of the virus is roughly, if somebody gets infected, it's on average, how many people do we think they are going to infect? If this number is above 1, it means that every person is likely on average to infect more than one other person. And in that case, we expect the epidemic to start to grow exponentially. If this number is below 1, then the epidemic is at a point where we expect it to start to subside on its own. And what you see here, so the estimated reproduction number for the city, initially it's high because when you look at the case data, the cases are climbing. And then at some point, the interventions succeed in bringing that reproduction number below 1, which is that horizontal line. And so the question we asked is, how long did it take for the city to bring the virus under control, for the social distancing measures to have the desired effect of bringing that reproduction number below 1? And we looked across these 58 cities at the relationship between that blue bar, how long till they intervened, and that green bar, how long did it take to bring things under control? And the upshot was that a 1-day delay in enacting that first measure extended the period where they had to fight the outbreak by about 2.5 days. And so if you extrapolate to the United States, that might mean that once an epidemic is brewing in a city, a 1-week delay in enacting those early stay-home measures might have meant, having to keep those measures in place for an extra 2.5 weeks, which we know can be very costly. So the final example of situational awareness is a study that we published more recently that's looking a little bit closer to home, particularly your home, and it's looking at the unseen emergence of COVID in Seattle. So as you probably recall, Seattle was home to the first diagnosed case of COVID in the United States. Patient 0 was identified on January 21st, somebody who had traveled from Wuhan. After that, the first identified case that was in Seattle that was thought to be infected locally was identified about a month later on February 19th. And there's been a lot of guesswork as to what happened between January 21st and February 19th. There's been some sort of genetic molecular analysis that first suggested that the case on the 19th was connected to the case on the 21st, so that there probably was sort of a continuous chain of transmission leading from that first case to that second identified case. And then there was a subsequent molecular epidemiological analysis that suggested maybe the link wasn't quite so strong. So there's a lot of a lot of uncertainty because we just weren't testing at that period of time. We didn't know what was going on. So by March 9th, not quite a month after that February 19th case, Seattle reported a total of 245 confirmed cases of COVID. And so we had the opportunity to take a retrospective look at this, piggybacking on a really important study that the Seattle flu study did. So they published this paper in the New England Journal of Medicine. The flu study is an ongoing study in Seattle that's just sort of been monitoring flu in the city to try to get a better idea of how flu spreads, and also looking at kind of the molecular dynamics of flu. And so this was already up and running. And so when COVID started spreading, this study was ongoing and testing lots of people for flu on a daily basis. And so the study went back and they said, and they kept all the swabs from the people they had tested for flu back in January, February, March. So they went back and they retested about 2,000 of those swabs for COVID, because back then they weren't testing for COVID. So they went back and they looked, and it turned out in this group of about 2,000 swabs, 442 had originally tested positive for flu. And when they went back and they looked, they found 25 cases of COVID that went undetected at the time because they simply weren't testing. So piggybacking on that study, we used that ratio of undetected COVID to detected flu to try to extrapolate how much flu was there in the city at the time. And the assumption we made was we could use surveillance data to kind of gauge how much flu was there all over the city. And the assumption we made was that ratio of COVID to flu in this small sample was probably reflected the ratio of COVID to flu sort of citywide. So we could simply sort of multiply that ratio by the prevalence of flu to get a sense of the prevalence of COVID. It's pretty simple. And so what did we find in doing that plus a little bit more analysis? Well, we sort of were able to backtrack, when do we think COVID actually started spreading throughout the community? And based on our analysis, we estimate that it probably emerged and started spreading continuously in Seattle sometime between December 25th and January 15th. So the more recent end of that interval does sort of correspond to when that patient 0 arrived in Seattle, but it could be that someone else arrived earlier and started spreading it in Seattle. We really don't know. And we also estimate that by the time Seattle reported 245 cases, there are probably closer to 9,000 cases in the city, including a good chunk of children. Maybe about a third of those were children. So Seattle, and like many other cities, probably had a lot more COVID than they realized in those early weeks before we were testing widely. In Austin, where we've done a lot of analysis and kind of tried to estimate when the virus started spreading, we estimate that it was probably circulating widely circulating sustainably in Austin about a month before it really got on we started detecting it. Okay, so though that was a whirlwind tour of some of the early studies we did and more recent studies really to try to get a handle on how this virus was spreading. I'm going to very quickly touch on these other two areas of modeling. So the next area is forecasting. And if you are following forecasting loosely, or maybe not even at all, but just happen to hear a little bit about in the news, probably the model you've heard about the most is a model that's been developed by a group in Washington called IHME. And this is a really nice dashboard that's been made available to the public and to policymakers. It's been online since almost the very beginning. And it provides projections at a state level, at a country level, and really for all around the world about COVID deaths and COVID hospitalizations and COVID cases. And it was one of the first to get a lot of attention by policymakers and by the public. And the first version of the model, which has evolved quite a bit, but the first version of the model made some simplifying assumptions and did things pretty differently than we've been doing it more conventionally in the field of sort of modeling and projecting infectious diseases. And the assumptions they made that were sort of unconventional are that deaths are going to follow a Gaussian curve. So deaths are going to follow a bell-shaped curve. And that was sort of the only assumption about how the virus was spreading. There was no mechanics of person-to-person transmission. It was just, we're seeing these curves in China, we're seeing these curves in Spain, in Italy, this is the curve we're going to see in the United States. And that was sort of the second assumption, that the shape of those curves would actually model or mirror what we had just seen in these other parts of the world. And that the third thing is the reason, when these curves would start to bend and go, slow and then eventually go downhill would be totally driven by when states impose stay-home orders. And so that, what the governor said would absolutely sort of guide transmission and the trends in mortality. And there are some issues with these assumptions. So, one is that deaths don't always follow a Gaussian curve, as we've seen as COVID has played out. We've seen lots of waves and weird shapes, right? What happened in the US didn't mirror China and Europe directly, although, New York looked a little bit like some of those other cities. And, when we look back at the data, people's behavior started changing sometimes before, sometimes after governor's orders. A lot of what was happening on a local scale. But this was their first, stab at it. Let's just try to do some kind of projection based on what we can see in the rest of the world. Okay, so the White House latched on to these and really brought this tool, this dashboard, into public awareness. On April 20th, as part of the motivation for the Reopen America plan, President Trump cited these projections as meaning that we kind of put the threat behind us. This is a quote from it. I think Trump says, "We would have had millions of deaths instead of, it looks like we'll be at about the 60,000 mark, which is 40,000 less than the lowest number thought of." So what I think this was referring to, which he used to kind of, again, motivate aggressively reopening America, is back when the White House asked a number of research groups to project deaths, and I think a number of groups, including ours, provided projections. The projections for unmitigated COVID were that 1 million or more people would die if we just let this thing rip. And then there were some projections that said, well, if we're very cautious and we keep these, we keep some of these social distancing measures in place, maybe we can cap it at 100,000. And I think, and so then he looked at this, and let me go back to this thing. They looked at this graph and said, wow, I'm looking out to July 1st, and the projection looks great. We've controlled this thing. We're gonna cap out at 60,000 deaths, and we're done with this, and we can go back to our lives. And what they didn't realize or acknowledge is that the projections in the IHME model, and you can even see this in the fine print, is that the projection that this is going to subside totally depends on us holding these really strict social distancing measures in place until at least, in this case, it was June 15th, and then only relaxing social distancing measures once we have ample testing, contact tracing, isolation, and limited gathering sizes in place. But it wasn't interpreted in this slide. So anyway, so that's how it got on the radar. So let's go back to the model. So the model had these issues that I mentioned, and it got a lot of flack. Some of it because of legitimate issues with the assumptions of the model, and a little bit with how they did the stats in the model. But a lot of it was, I think, a matter of style. I think a lot of the critics of this, folks who come from my world, were they just didn't like this kind of curve fitting approach. It wasn't the way we usually do our modeling. It didn't take into account the mechanics of transmission dynamics. And so I think that they just, they sort of felt like they prejudged it in a way. And in fact, some of the criticism was because of actually the poor performance of the model. So this is a graph we made, but others made graphs like this. This is showing the model's projections for Spain with that line and that shaded area compared to what actually happened in Spain, which is those dots. And you can see often the way the pandemic actually played out fell outside the 95% confidence intervals for the model. And so we decided not to fully throw the baby out with the bathwater, but to think a little bit harder about this approach. Maybe there is something to say for curve fitting, particularly maybe in the early phases of an epidemic where you don't really know that much about the transmission dynamics. Because if you do look, when we look around the world, we do see these sort of, at least early in the pandemic, these sort of stereotypical curves. So we built our own version of the IHME model that tried to kind of improve on or fix a couple of the issues. We do have a forecasting model online that does project deaths. It's not this original version I'm going to tell you now, but the original version of our model did a couple things. One, it fixed a statistical error so that instead of having shrinking confidence intervals as you go further in time, it has appropriately increasing confidence intervals. But more importantly, what we did was we no longer assumed that what would happen in the US would mirror what we saw in other countries, and that what the governor said would absolutely dictate what actually happened on the ground as far as transmission. What we did instead was we looked to the cell phone mobility data to try to gauge what was really happening on the ground as far as how much were people really staying home, social distancing, keeping away from public places. And in fact, I believe our model was one of the very first models to use this kind of cell phone mobility data to inform the transmission rate in our model, or the trajectory of COVID in the model. And we've been, ever since, we and many other groups now have been analyzing this kind of data. So what you see on the right here is data that we get on a weekly basis from a company called SafeGraph, which provides this kind of data pro bono to many different research groups. And there are lots of different variables you can request and track. What we are looking at in particular, we get this at a census tract level, and we aggregate it at whatever level we're trying to make projections. So, at the city level, the state level. But the kinds of trends that we're tracking are, the top graph is what proportion of the day are people staying at home? And that's, how long is their cell phone at home? And what you see, and this is going from kind of the beginning out through, I think this goes out through actually maybe the end of August or early September. And this happens to be Austin, I'm showing you here. But, so people were not staying home much until we imposed the stay home orders, and that spike, around April is us starting to stay home, and then we start going out of our houses again in late spring, early summer. All of the variables below that, those are numbers of visits to different points of interest. So how many people per day are visiting restaurants, bars, grocery stores, parks, doctors' offices, schools, and college campuses. And if you stare at these, you can tell good stories about all of them that kind of correspond to when we were forced to stay home, when we started relaxing, when schools started opening, when college campuses started opening, and you can see it in our behavior. So our model is one of, I think now, over 20 different models that feeds into the CDC's COVID-19 mortality forecasting ensemble. So the CDC is taking a very sensible approach in looking at what all of the models are saying. There's no one model that is perfect. Each of the models that have been developed since the beginning of COVID is developed by different types of researchers with different expertise, different technical tools, different access to different kinds of data, and brilliant people from all across the spectrum of the disciplines. And so the CDC is really looking at this as sort of expert sourcing, in terms of trying to get a robust understanding of what might happen in the coming weeks. And it's a very kind of sensible approach. They're even doing some formal ensembling where they're actually taking some averages to kind of come up with Uber projections. And it's really the way to go. And the kind of the infrastructure for this kind of ensemble or group modeling was really put in place before COVID. Over the last few years, the CDC has really tried to jumpstart and invest in forecasting resources for epidemics. And a lot of the effort before now has been focused on influenza and to some extent dengue. So this is a conversation maybe for our second hour, but it really, really important, I think, this point of discussion is, why is it so hard for us to forecast a pandemic like COVID, in comparison to forecasting the weather? I'm not going to go into that now, but there's a lot we can discuss. I'm going to turn finally to just an example of how we're using models to help decision makers figure out how to make decisions that slow spread, save lives without costing too much economically, societally, health-wise. And I would say, this is probably where the majority of our time is spent, is just like talking to people, building models to try to help them, whether it's individual schools or cities or states, helping them to try to understand how to make sense of the model and navigate the challenges that we've been facing. So going back all the way to my first two slides where I said we developed this model we were in the middle of developing this model on a national scale that we rapidly retooled for COVID. So this is a model that we have been retooling almost on a weekly basis. But the basic original model was that we had a meta-population model that had separate models for the 217 largest cities in America. In each of those cities, we had a very detailed mass action model, a compartmental model, that captured the makeup of the city. So in each of these cities, we had histograms like these where we broke down the city into 17 or 18 different age groups. In each of those age groups, we had local estimates for what proportion of people had high-risk conditions for severe outcomes for influenza, which turns out to overlap quite a bit with high-risk comorbidities for COVID. We also had a separate model estimating the number of pregnant women in each of these age categories. So the model includes some of these details for a city. And then in each city, we have a compartmental model. This compartmental model has evolved and been adapted for different purposes during COVID. But the basic idea is we use systems of stochastic differential equations to track the movement of people between different states in the epidemic. And so a person can, for example, be S, that's that blue box on the left, so they're susceptible, they haven't been infected yet. Once they get infected, they become exposed. In the most recent version of our model, we actually explicitly model day to day what's happening to a person in terms of how infectious they are and the likelihood that they have symptoms on that day. And then we can track whether people are detected. The D's in this particular diagram mean they were tested and identified and isolated. We track how many people are hospitalized. In some cases, we track how many people go to the ICU, die, et cetera. So in each of the cities, we have a model. Along with each one of those boxes is a differential equation. And in each of the cities, we basically have a model like this for every age and risk group, because we want to track separately what's happening to high risk, 20 to 40-year-olds, and we want to, what's happening to low risk children, in the city. So we have these models for each of the different groups in each of the different cities, and they speak to each other because they can transmit to each other. People can move from one city to the next. So that's kind of the gist of how we're modeling this. And when we focus on specific populations, we can kind of pull out one city at a time or a state at a time and model the transmission dynamics for that jurisdiction. So the one example I'm gonna go through briefly is modeling work that we've been doing on an ongoing basis to support the city of Austin in developing and applying policies for COVID management. A lot of the modeling that we did was really upfront in the beginning, as they were looking at first trying to decide, if and when to enact a stay-home order, and then deciding what sorts of measures and plans to put in place as they were, in fact, sort of forced to reopen when the state of Texas started aggressively following the federal mandate to reopen. So what you see here is Austin's playbook in a nutshell. So Austin, like many cities, has a couple dashboards where you can track what's going on in terms of cases and hospitalizations and deaths in the city. You can look at it by zip code. You can look at it by a racial and ethnic group. You can look at it by age. So they have a really big complicated dashboard with all those features. They also have a separate dashboard, and the one that you're looking at, specifically dedicated to what stage, sort of tracking what stage we are and should be in as far as what kinds of measures we have in place to slow the spread of virus. So, like you've probably heard of this maybe in your own cities or in other cities, we have this sort of color-coded scheme where if we're in red, that means things are spreading quickly, things are really dire, and we basically need to be staying home. If we're in orange, things are spreading at a brisk pace. We don't necessarily need to stay home, but we need to be doing everything we can to kind of slow transmission. Yellow is a little bit more relaxed. Blue is really pretty good. Green, we won't be at until we get to the end of this pandemic. And so what we helped Austin to do is kind of think through what should the playbook look like, what should the little different levels do, and importantly, where kind of the number crunching came in is deciding what is actually the break point, the numerical break point between red and orange and yellow and blue, and what data should we be tracking, so that to know what number we're at. And so to get to the point that we got to, and this, I think this was put online in mid-May, and it has sort of stood the test of time so far, this is sort of the analysis that led to this. So back in, and this is projections that we did back in, and I'm going to go ahead and back in early May, and what you see in that inset in the upper right is the real data. So the red dots are how many hospitalizations for COVID had been reported in Austin up till that point in time. The black line and error bars are sort of our model fit to that data. And what you see from kind of mid-May on is our projection for what would happen if after relaxation of the stay-home measure, we stayed relaxed. We didn't necessarily bounce back to the transmission rates that we saw in Austin back in early March, but we bounced back quite a bit. It was actually, we bounced back about halfway to what the transmission was we estimated for early March, and we just let things go from there. We didn't do anything. What we projected, and these are hospitalizations on the x-axis, is that, and the horizontal line going through the middle was at that point in time what Austin had estimated to be its capacity for safely treating COVID hospitalization. So at that point in time, they thought they had about 1,100 beds to treat COVID patients on any given week. And so what the projection was that things were gonna be horrible, that by the middle of the summer, if we don't do anything, we would exceed hospital capacity, not even accounting for the excess deaths of people from COVID, from other illnesses that didn't get safe and effective care. There would be at least 3,500 deaths, by the end of the year. And nobody wanted that. No matter how much you wanted to open America and revive the economy and bring kids back to school, nobody would let it get to that point. Everyone is going to throw on the brakes when the hospitals in Austin start looking like the hospitals did in Italy or in New York. And so the question was, how do we avoid this? And we were thinking this through at a point in time where Austin had a lot of sort of legal policy constraints. The governor of Texas wanted to open up the state, and he was not allowing local authorities to deviate much from the state plan. And so, for example, Austin could not extend its stay-home order. At that time, could not enforce face masking. At that time, could not, close restaurants or bars or industries like construction more than the state was willing to allow. And so how could we come up with a policy that was feasible from the perspective of what was allowed, but also would ensure that we never sort of got to this point? And so, a lot of the sort of heavy lifting was just kind of thinking through the structure of a plan. So the first question is, what are feasible goals to kind of, given those constraints? And what we ended up with was we wanted to come up with a policy, at least at that point in time, that would ensure that we never had an overwhelming number of COVID hospitalizations. So we would stay under local capacity, but also we would reduce the amount of time we would be under restrictive orders. We would avoid stay-home orders if at all possible. So hope we never get to red, minimize our time in orange, and keep things as open as possible for as long as possible. So shorten the duration we have to spend under restrictive measures. And then the policy options, and these are things that sort of the city fleshed out and looked around the world, and the policy options were basically what would end up going into the list of things we do in orange and the list of things we do in red, list of things we do in yellow. When do we mandate face masks? When do we close restaurants? When do we allow them to open 25% capacity? When do we say groups of 2, groups of 10, groups of 25, et cetera? And so those are the different policy options. And then the questions that we answered with our modeling are what data to track. And once you decide what data you're tracking, when to act, when to tap on the brakes and move into these different levels. And the question of what to track at that point in time turned out to be kind of an interesting, it was a very interesting question that led us to really kind of think hard about the data that were widely available. And the case data continues to be very difficult to interpret, even case positivity, because it really depends on who's being tested on any given day, whether they're testing asymptomatic, whether they're testing symptomatic, what the rules are, how many people have access to the test. So it's really hard to directly use case data to get a good signal for transmission rates. Death data, which were also widely available from an early date and are somewhat reliable, although we know now that they probably undercount the true number of deaths. The problem with the death data is that they're lagged in time. Now, when people die from COVID, it's typically at least 3 weeks after they were first infected. So if you see an increase in deaths, what you're probably seeing is a signal that transmission was increasing, about a month before. And so that doesn't give us a good real-time indicator of what's going on. So then that left us hospitalization data. And hospitalization data, usually what you see is what we call census data, or heads in beds. It's the total number of people in hospitals on a given day for COVID. And that data is useful. However, it's a little bit hard to interpret because how many people are in a hospital depends on how long a person stays in the hospital. And there's a lot of heterogeneity. People who die sometimes end up spending a much longer period of time. It depends on the age group of people entering the hospital. So there's a lot of heterogeneity that you kind of have to sort through if you want to take hospital data and try to infer from it transmission rates. And so what we landed on is potentially the most reliable, informative, real-time signal of transmission is daily hospital admissions for COVID. So how many newly admitted patients are there for COVID? The problem with this is that it's not widely available. It's a little bit difficult for hospitals to provide that. They're not mandated to provide that. It sometimes requires kind of backfilling the data because somebody may be admitted on one day, but not detected as a COVID case for 2 days later. So 2 days later, particularly when testing had long turnarounds. However, when we recognized that this would be a useful source of data, we were involved in this really unique sort of task force in Austin where the mayor, the county judge, heads of the medical school, CEOs of all the hospitals in the area, the public health authority were all meeting 3 times a week, and everybody was on board with trying to get the best data, the best decision-making possible. And so the hospitals very quickly responded to the request from the city and started providing this on a daily basis. And so it's hard to get this data. There are not many cities where you can find this, but Austin's been providing this on a daily basis from all the hospitals. So that's what to track. And then finally when to act. And that's the complicated analyses we did where we used that model I described before. We used numerical optimization to try to figure out when exactly, what level, when we're tracking those hospital admissions, at what level do we know it's time to slow things down, so we don't exceed hospital capacity? And when do we know that things are looking good and we can start to relax things? And so that led to that policy I showed you. What I'm going to show you now, in contrast to that yellow graph I showed you where things just exploded, this is a projection that we made kind of early in the summer, but I've updated it with some data from more recently. This is not a forecast. This is a projection that if Austin follows the policy as written and people in Austin obey the rules as written, and we are approximately right about how those rules will translate into reductions or increases in transmission, this is how things would play out if we kind of follow that policy. So this is just a scenario projection, not a forecast. But if you squint your eyes, you'll see there are red dots up through September. I believe we made this projection kind of towards the end of July. So the correspondence between the dots, from August and September are kind of a little bit of a validation. But beginning in mid-June, actually, we started putting on the brakes again because we were having this alarming surge in transmission. And we went into we went into orange. We enforced face masks. We did a lot of other things in Austin that had the desired effect of really slowing transmission. And so we've been under this kind of orange period that's had the desired effect. If we go into yellow, if we're already in yellow and going back to school and the relaxation we know is sort of happening on the ground is leading to an increase in transmission. I don't know if you can see this, but one thing you can see here is that you don't actually see the uptick, towards, until like 2 or 3 weeks after things start relaxing. We may get to a point in mid-orange where we need to, put on the brakes and go into orange again in mid-October. We may even have to go into red in November, and then ultimately sort of run its course. We assume that, that infection is immunizing and we end up sort of achieving herd immunity at some point. So if, this is sort of what the policy is meant to do. It's meant to ensure that we don't spend too much time in red and we never exceed hospital capacity. And we'll see what the future holds. And in this case, even though we're not optimizing to reduce deaths, we expect that this would reduce deaths quite a bit relative to what we project if we don't take action. So hand in hand with developing this policy, we've also developed a model to use that hospital admissions data and the cell phone mobility data to, on a daily basis, provide situational awareness and short-term forecasts in Austin. This is a screenshot from one of our dashboards where on almost a daily basis, we're estimating the reproduction number in Austin and the chance that we're in an increasing or decreasing phase in the epidemic. We make short-term projections for what's going to happen in our hospitals with respect to COVID. And this is the admissions data projected out for a few weeks. And the other thing we do, we project also ICU needs and hospital needs. The other thing we do at the very bottom of our dashboard is do a look back at what we think's been happening with the transmission rate in the city. So this is a look back at the reproduction number in Austin. And what you can see is we estimate that before we enacted the stay home measures in March, the reproduction number in Austin was probably somewhere between 2 and 5. We really don't know. It was probably spreading pretty quickly. Schools closed. We enacted our stay-home order. Reproduction number was brought under 1. We start our phased reopening in Texas. So we have early May as, day 1. Phase 2 happens mid-May, and then you start to see the increase in the transmission rate as people start to relax. When things got really alarming in hospitals, the governor allowed local authorities to enact stricter measures. Those start to have the desired effects, and then things looked really bad in the state, and so bars closed around the states. Then there was a statewide face mask mandate, and these helped things locally. And ever since then, we've been kind of cruising along right around, R not equal 1. So, and we're at this point where there's a lot of uncertainty. Like I said, we don't know what's happening. Where that error bar goes below 1 and goes above 1. It could be that we're at a point where things are increasing because UT, is back in town and schools are starting to open, but we don't know. And so far, things are not looking alarming. Although certainly lots of people are still getting COVID and people are dying and ending up in the hospital. So it could be better, but it's not like it looked in June, and we'll see what's going to happen. And I'll just end by saying, a lot of the conversations that we're having now, let me say one thing is that we also have built a version of that dashboard for all regions of Texas. We got a call shortly after that went online from Austin, from the state agency, asking whether we could do something similar. And we are able to do something similar across the state. However, we don't have admissions data. So it's a little bit rougher estimates based on the total heads and beds data, but it is something you can do with the heads and beds data. And I'll just say, this is my last slide, that most of the conversations I'd say we're having over the last month have really been around opening schools. How should we ramp up testing in schools and in communities as a strategy for mitigating now that tests or as we hope tests will become cheaper and more widely available? And what should we be thinking about as we look to the rollout of vaccines in the spring? So with that, I will just mention that, this has, the things I've described have been, the heroic round-the-clock efforts of dozens of people from many different institutions who have collaborated, brought different disciplines, different perspectives, and a lot of heart to trying to do what they can to help bring data, science to the folks on the front line who are, really have the hard job of protecting all of us. So thanks so much. Happy to answer questions. Look forward to the conversation.
Thank you so much, Lauren. That was fabulous. I suggest if people have questions that they, just say something in chat, and I think there's been some conversations going on. I'm trying to, Kent Nelson, are you still on? Did you have a question?
Do you want me to go through the questions in the chat?
Holly, yeah, Holly, I am, but I have to sign off for another meeting at 1:30. I may try to sign back on. If you're interested, I might talk a little bit about how I'm the university's lawyer, how we worked with the modelers to apply the law and to advise the administration on what we could and couldn't do for testing under the laws. It was a great team effort. It's been really fascinating for us, but I've got to sign off now for at least probably a half hour or so. So
I'd love to
enjoyed this very much.
Okay, we'll see you if you get a chance to come back. I think the earliest stuff was more discussion as things went along. I think Nathan, you had a question, if you're still there. Nathan Taggart.
I can read it out if you want me to.
Yeah,
just, okay.
Let's start with Nathan's, that's fine. Okay.
So Nathan says, I thought the virus didn't survive for long on surfaces, or is it that it doesn't remain infectious for long? I think that the studies, some of the early studies suggest that the virus can survive on some surfaces for an extended period of time. But the little work I've seen that tries to sort of tease out what proportion of transmission events are through droplet transmission, aerosolized transmission, or foam mite transmission, like surfaces, it seems like the preponderance of evidence is that it's primarily droplet and aerosolized transmission. Not a lot of examples or anecdotes of people actually likely have been infected by contamination on a surface. That doesn't mean it can't happen, but it doesn't seem to be the reason for a lot of the transmission. So Oh, I see. And this was asking, yeah, these were storage samples stored at cold temperatures. They were swabs taken from, you're talking about that, yeah, swabs taken from the noses of people who were tested for.
So if you go down and you see Kent, then right below that, Nathan had another question, and that's where I think the questions start as opposed to the discussion.
Oh, okay, which one? What's the difference between?
Right below Kent Nelson, there's Nathan Taggart again, and it's what is the difference between forecast and a projection?
Okay, so I mean that's just word that I'm using, but I mean the reason I like try to emphasize or make a point that I'm not using the word forecast is because I think when people hear the word forecast, they think you are making a projection of what you believe will happen based on all the data you have up till today. And so in that case where I was saying this is like a scenario projection and not a forecast, I don't necessarily think what I'm was showing you is the most likely thing that's going to happen, because there's just so much. I don't know what the city's actually going to do or what the state is going to do, you know, or what's going to happen. And so I think there is so much uncertainty around around policies and human behavior that I won't go out there and say this is what's going to happen a month from now. I think the horizon we feel comfortable saying is a forecast is about 3 or 4 weeks, you know, in these models where we're projecting mortality and hospitalizations. And part of why we sort of set that as our forecasting horizon is that it's what's going to happen as far as hospitalizations in the next few weeks and deaths. A lot of that's already been determined by the transmission that's happened on the ground up till now, you know, because it takes a little while for somebody to end up in the hospital or to die. And because there's inertia in behavior and in what's happening with the thing. And so even if we don't know exactly what's happening on the ground in terms of people's behavior, you know, next week, it's probably not going to change radically, you know. And so we're willing to kind of assume there's some inertia in behavior, taking into account the lags between behavior and transmission and in transmission and hospitalizations and deaths. We feel comfortable saying, okay, our models can tell us something about what's going to happen a month from now, but not much further out than that.
So the next question has to do with, could using COVID-19 hospital admissions data miss other modes of transmission, for example, younger people, or people who chose not to go to the hospital for various reasons? And also, how did you get your threshold lines?
Yeah, so those are great questions. And I mean, the answer is yes, we're probably missing a lot. I mean, so the reason we're using hospitalization data, or at least originally the reason is because it wasn't because it was hospitalization data and because that we want to protect hospitalization. It was like, we just wanted the best indicator of the transmission rate in the community. And the other data sources just were either too lagged or too noisy. And so, but what we saw in June and what we're like concerned we're seeing now is when you have this kind of demographic evolution of who's getting infected, when you have younger people and it takes a while to get out into the more high risk parts of the community that ends up in the hospital, we may be missing early upticks in transmission because we're not going to see that until people start getting hospitalized. And so we would really like to have more direct data on infections and transmission. And we even we went back and we said, okay, well, maybe the case data is a little more stable now, right? Like testing is stabilized a little bit. We have more access to like information about who's being tested, how many. Maybe we can actually use that as an earlier indicator. But what we found in Austin, and we just did a quick analysis, and this was just a week ago, but is that it still isn't giving us that early signal. Like we know we're probably missing something, but that data still isn't high enough quality to kind of fill in the gap. And if you think about it, I mean, we may be missing the younger, healthier people if they're getting, disproportionately infected right now, or, they're the ones making a lot of the transmission. But as far as like the lag, case data is not really going to shorten the lag that much because, most people don't get tested until they have symptoms. And, maybe there's a day or so before they go get tested, a day till they get the results and it gets reported or whatever. And if somebody ends up in the hospital, they're typically end up in the hospital within 5 or 6 days of having symptoms. So maybe we cut a couple of days, 3 days off the lag, but we don't gain that much time in terms of the case data. But anyways, So the answer to that part of the question is we probably are missing, if there are bursts of transmission in young people or, college campuses, we won't see that immediately in hospitalization data. And then the other question about the threshold lines, I really didn't explain that. So what we did is we used that sort of compartmental COVID transmission model. We did this for Austin. So we had a lot of detail built in about the structure of Austin, the demographic and risk makeup of Austin. And then we sort of embedded that model in an optimization procedure that it did sort of numerical optimization where we would run lots and lots of simulations. And in each of those simulations, we would try out different thresholds. And we basically we sort of efficiently searched the space of all possible thresholds to find ones that would provide these guarantees, would sort of guarantee with 95% certainty that we would never exceed hospitalizations, and would simultaneously minimize the time we were in red or orange, and we would just penalize time with, we made some assumption that the cost of being in red is 100, the cost of being in orange is, I don't remember, 10, the cost of being in yellow is 1, whatever. And so we would penalize time spent in those different things and use numerical optimization to come up with what was a decent strategy and with some guarantees.
How do restrictions or lack thereof in neighboring states or cities affect transmission? Did you consider that in your models?
Yeah, we really didn't. I mean, so we can consider that in our models, but I think at the time that we did that analysis, I don't even remember what the motivation was, but I think it was sort of two things. We'd probably be in kind of one of two worlds, and this may be incorrect, but we'd either be in a world where things were sort of locked down and there'd be very little movement, or things, I guess it's three worlds. Things were locked down, very little movement, or things would be sort of similarly locked down everywhere. So if there was movement, it would be kind of like same levels moving back and forth, or the transmission would be at a level like it is today, where even if we're having importations, those are just drops in the bucket, because we have so much virus in the city that it's spreading without the help of people coming in. That said, I mean, maybe we could be wrong, and we could absolutely be in a situation where we should be considering the different levels of different prevalence of virus in different cities. We did take this into account when we were doing some kind of helping UT think about reopening. And we specifically looked at the zip codes where the 17,000 students who were about to come back to Austin, where they were coming from. And based on that analysis and the prevalence of COVID at the time in Austin, I think we estimated that when they showed up around August 18th, prevalence among kids coming back to campus would be about double the background prevalence in Austin, because they tended to be coming from areas, particularly in Texas, that still had higher levels of prevalence. But so, it certainly is important in contexts like that. A good question.
I think you answered Courtney's question about methods. Barry? Do you adjust? Yes.
Okay.
Go ahead.
Okay, yeah, so the question is about how are we anticipating the upcoming influenza season? And I'll say we've talked about it a lot. It's come up, basically the way it came up in conversations with the city, and we've been talking about it since early summer, is we've sort of put it back to the hospitals. Hospitals had to dig deep and kind of revise their estimates for what is their safe capacity for COVID. And first it was 1,100, then it was 1,500. And so we posed a question to them of, what's your safe capacity going to be during flu season? When a lot more beds are going to probably be needed for non-COVID cases. And we've never gotten that, and I think it's just because other things have come up, but we've never gotten the revised estimate for how many ICU beds and how many general beds are going to be available during flu season. And, the plan was, and we might still do this in the coming weeks, right now we're not close enough to a threshold that we need to worry that we may be off. But what we're thinking to do is just take that revised threshold and re-optimize for triggers that would make sure we stay under, instead of 1,500 beds, maybe it's 1,100 beds or something like that. So one thing we are doing, though, we have a project that's funded by the Society for Medical Decision Making. We're doing some modeling now around trying to project. So the idea behind that way of thinking about it was just tell us last year how many flu cases you had, and we'll deduct that, right? But now we're doing some more dynamic modeling around what might it look like in flu season when where there's two things that are going to kind of be key predictors. One is social distancing measures for COVID will hopefully also reduce transmission for flu, and levels of uptake of flu vaccines will also potentially impact dynamics for flu. And so we're doing this kind of like two input analysis where we're varying both of those things and looking at what it might look like. And so with that, we'll probably have projections for how that might change hospital capacity. But at this point, those triggers for Austin are still based on assuming 1,500 beds in Austin. Yeah, and one thing that happened that was really kind of alarming and interesting was in June when, for those of you who aren't in Texas, I don't know if you follow the blow by blow, but Texas kind of blew up in early June. We just had that really sharp uptick in hospitalizations, and to the point where I'm sure you heard in the national news that hospitals in the Rio Grande Valley and Houston were filling to capacity, and they were shipping in healthcare workers from the military to provide additional support. And things started to look a little bit alarming in Austin. And that's when, we hit our trigger point and we enacted measures. But one of the things that we realized in that very precarious moment was that we had built all of our policies and done all of our thinking around ensuring we never exceed 1,500 hospitalizations for COVID. And it turned out that we were going to hit capacity on ICUs before we hit that 1,500 bed capacity. And I don't know, even looking back, I hope some way we'll unpack this. I don't know how everybody, these are the executives of hospitals and, folks on the front line caring for patients and the public health people and us who are modeling, and we know what the ICU fractions are. All of us sitting around this room, nobody thought to say, wait, we're optimizing we're not optimizing, we're going to hit a constraint before we hit the total number of beds. And so, at that moment when we realized we're going to run out of ICUs before beds, we did re-optimize for ICU capacity. And what we found is that we probably should move the triggers a little bit earlier because the ICU capacity is lower than the hospital capacity, given right now what the proportion of COVID patients who end up in ICUs is. But it was close enough to the original triggers that we're kind of keeping that kind of behind the hood or under the hood or whatever, because we don't, as far as public messaging, the city doesn't want to keep changing the thresholds. But we know that if we start to get to the point where things are looking alarming, we're probably going to want to relook at the numbers and possibly enact measures before we hit the original thresholds.
Well, there's lots more questions.
Okay. Let's see.
We're on Mohammed Makib.
Okay. How do you assess your model? What are criteria used to measure the accuracy of your model? Just looking on prediction intervals, or you use other criterion? Okay. That's a really good question. So, we've tried to either validate or test kind of consistency of our models to data in different ways depending on the model. And with the Austin model, we approached it in different ways. First of all, the model is fit to data. So, in sample, it's got to match, what's happened in the past as far as hospitalizations and cases and deaths. But we also typically reserve some data for sort of out of sample consistency checks. So that'll be like in that one graph I showed you, we'll fit up to early August, but leave out August data, make the projection and see how it matches, just to make sure things look roughly consistent. In some of our forecasting models, sort of the Bayesian methods that we're using sort of do some of that kind of checking for consistency as it goes. But we also do backcasting, and where we go back and we say, okay, what did we project 2 weeks ago, and how does that compare to the data? And often our models aren't doing a very good job. Sometimes they do a great job, sometimes they don't. And actually, I showed you that graph of, I showed you that screenshot of the CDC's forecasting ensemble. Well, there's a researcher named Nick Reich at UMass Amherst who is really the curator of all of those forecasting models, and also one of the real pioneers in developing epidemic forecasting models. And he also is building some of these ensemble models where he's taking all the results in. And he has a visualization tool that has the exact same forecast in it as the CDC's website, but it actually allows you as the user to do the backcast. Like, you can take your mouse and you can go back to, what did all these models say on September 1st and what actually happened? And so he's doing this sort of for the community, allowing us to see how good or how crappy the models are. And there's no one model that's great. Nate Silver's 538 also is doing a bit of kind of keeping tabs on the models, and they're ranking the models for accuracy using different metrics. And for a while we were one of the top models. I don't know how we're doing now, but there's so much, that it's just, this is sort of getting to the question of can we forecast this pandemic? And it's really hard because, the data are incomplete pictures of what's going on and sometimes really biased. And, most importantly, we just have no idea how people are going to behave and what policies are going to be put in place. And that, those things just dramatically shape how this thing is, unfolding. And so it's harder. And we were able to do a much better job. Well, I don't know if we were able to do a much better job for flu because we didn't have as good technologies when we were doing this for flu even a year ago. But comparatively speaking, flu was more tractable to forecast during, a typical flu season because people's behavior was a little more predictable. And like all of those, a lot of like what people assume in these models about the underlying behavior that leads to the transmission of virus is based on things like diary-based studies, where they've gone in and they ask people to record on a daily basis, where did you go? How many people did you interact with of different age groups? And then from those kind of diary-based studies, we can say, okay, on a typical day, how many contacts do 5 to 10-year-olds have with other 5 to 10-year-olds in schools or out of schools, or adults in workplaces, et cetera. And those went into those kinds of, that kind of data was kind of part of the structure of our model and many other models like ours. And a lot of that just we had to throw out the window once we started going into these sort of unprecedented, stay home orders and work restrictions and school closures. And so it's really hard to gauge what's going on underfoot and how that behavior is changing.
So somebody wanted to talk about herd immunity.
Yeah. Okay. So I mean, herd immunity, there's so many aspects of herd immunity that are really interesting to discuss. So, so for those of you who are not familiar with the term, but I think everyone is now familiar with the term, but it's the idea that we can get to the point where there are enough people with immunity to this virus in our population that the virus will stop spreading. And that doesn't necessarily mean that 100% of people have to be immune. We just have to have kind of built up enough immunity that there are not enough susceptible people around for the virus to keep spreading. And so we can achieve herd immunity in a couple different ways. We can achieve herd immunity naturally, in the sense that, if this virus is partly or fully immunizing, then, once enough people have been infected and cannot get reinfected, at least in a short time horizon, we may run out of susceptibles, or, we may have depleted susceptibles enough. Or, we can start vaccinating people, and that can also provide some immunity in the population. So, but herd immunity, there's a lot of discussion around herd immunity around what is actually the threshold in terms of the number of people that need to be immunized in order to bring the reproduction number below 1 so that the pandemic does start to subside. So is it that we need 15% of people to have been infected, 25%, 50%, 70%, 90%? How much infection do we need to have experienced before we're kind of finally done with this? And the very simplest models that just assume a homogeneous population, everybody's kind of the same with respect to how susceptible they are to the virus and how infectious they'll be once they get infected. Those simple models, when fit to like the early data on COVID before we enacted social distancing measures, they suggest that if our population was that simple, a whole lot of us have to get infected before we achieve herd immunity. Like we probably need to have like 70% or more people infected before the virus will kind of be self-limiting. However, there are a lot of reasons why that may not be what we need to achieve. And one reason is that, we may be okay with wearing face masks and a certain level of social distancing as long as we can kind of go to school and kind of go to work. We may be okay living in that world for years until we get the vaccine. And if that's the new world we live in, then the herd immunity threshold will actually be lower because the virus is just going to be spreading at a lower rate, right? The herd immunity threshold just sort of depends on how fast the virus spreads. So, if we're if we're living in a new world where the virus just doesn't spread as fast because we're willing to do kind of the minimum to keep it at bay, the herd immunity threshold will be over. One of the important points of controversy, though, is that's come up. Some have been politicized, somewhat out of kind of like just scientific disagreement, is whether or not there is enough kind of intrinsic variation, heterogeneity in our population and susceptibility to infection to lower the herd immunity threshold. So mathematically, if you add to your model the fact that we're not all the same with respect to how likely it is we'll get infected if we're exposed, maybe because we have prior immunity from exposure to a different coronavirus, something else kind of about our physiology, biology, immunity that just makes us less. It could even be, sociological. We're people who always stay at home, so we're never going to be exposed. But if you put in your model the fact that there's not everyone is equally susceptible. There are going to be some people who are maybe highly susceptible to infection and others who are maybe not at all susceptible to infection. The more heterogeneity there is, the lower the threshold is to achieve herd immunity. And so, and you can show this mathematically, and it's very sensitive to how much heterogeneity there is. And so recently there have been some researchers who have published papers where they've taken data from these sort of early pandemic curves, and they fit a model that allows for different amounts of intrinsic, sort of variation in susceptibility. And they've also in their model allowed for different levels of social distancing. And they fit their model to data to try to say, based on the data we see, based on the shapes of those early curves, is there evidence that what slowed those curves is that intrinsic heterogeneity, or is it the social distancing, or is it some combination of the two? And there have been a couple preprints that have come out that make the strong argument that the data tell us that there's so much heterogeneity that the herd immunity threshold is actually 15%, so we're almost done with this pandemic. And I think in looking at the analysis, I think it just doesn't quite hold up. I think that they sort of, maybe not intentionally, maybe I shouldn't say it this way, but they sort of cherry pick the data. Like they fit this model to the first wave, for example, in Spain, and they said, okay, so therefore we're basically done with it. We've hit our herd immunity threshold, and they haven't taken into account the enormous surge in the pandemic that's happened over the last month or two. And I think there's just some statistical issues with how they're doing the fitting in the model comparison. But, that's again, us kind of doing a close inspection. People who, for one reason or another, want to believe we're close to the end of this have really latched on to some of these studies and are saying, because we've, a lot of America is maybe already close to the herd immunity threshold because, we have seroprevalence studies telling us that 25% of New Yorkers are already infected. And, the national average is around, CDC just came out saying the national sort of average seropositivity is somewhere around 10%, but it varies very much depending on where you are in the country. So it's a long answer to the herd immunity question, but that's a really active, highly politicized debate right now, is what is the sort of that intrinsic herd immunity, kind of setting aside what our interventions are going to do for us. And then the other considerations that we have to think about with herd immunity is how immunizing is infection, right? Like we really don't know. And there have been some alarming studies saying, well, we don't detect antibodies in a small subset of cases, a month or two after. And that's, I don't think that's in any way conclusive, but it just raises the possibility that not everybody is fully immunized. And you hear the occasional somebody being testing positive again a month or two after they were first tested positive. So I think there is some uncertainty around how immunizing infection is. And then I think as we're looking towards vaccines, I think that there's really a lot of uncertainty about how efficacious the vaccines are going to be in terms of preventing infection. And there may be different levels of effectiveness. They may be good at preventing severe outcomes, like maybe you'll get infected, but you're less likely to get really sick. And so that may not do a whole lot with respect to slowing transmission, but it may, the more people get infected, the more it'll make it a less severe disease for us. But I think, so there's a lot of different things that, kind of go into herd immunity, but based on, so to answer your specific question, will we achieve herd immunity before the vaccines? I think that if this thing is allowed to spread widely without much intervention, some communities could achieve a high level of immunity. But I think that's a scenario where we are seeing catastrophic numbers of hospitalizations and deaths. And so as long as we're kind of doing things to kind of repress transmission and try to keep it kind of at levels that it is or lower, I think it's a long haul. I think we're talking about, in that one last picture I showed you where we finally, maybe get something close to herd immunity, but that's still in a situation where we're still wearing face masks and doing stuff. I think that was going out till the end of 2021.
Lauren, there are a couple more questions, and then what I'd like to do after those is let you kind of direct what you'd like to talk about.
Okay, great. Okay, herd immunity. Okay, I just answered that one. I know that there are wastewater surveillance efforts in Austin. Can you talk about your thinking how to incorporate that signal into the estimates of transmission? What about other data streams like test positivity ratios? So we're really just beginning to think about this. I mean, so for other, let me get to the wastewater in just a minute, which we've not given as much thought to. But for other kind of data sources like mortality data or test positivity data or just test data, confirmed case counts, the way we typically integrate that kind of data is we just explicitly model the observational process in our model. In the sense of right now we have compartments for hospitalizations. So our model is spitting out hospitalizations per day, and we can kind of fit that to the reported hospitalizations per day. And so, if we wanted to try to fit to test positivity, we would have to add something about testing efforts. So we sort of have that denominator or whatever, or, but we basically figure out a way to model, add to our model what we need to. So our model is basically projecting the test positivity from the dynamics and then compare that to the test positivity. So that's kind of how we do it in general. We just kind of we replicate what we think is happening in the real world as far as the observational process and compare that to what we're observing. With wastewater, I mean, I think maybe Jennifer, you may have thought about this more than I have, but we're only really beginning to kind of think about what this means. In fact, we had the people come present to us a while ago from the group at UT that is trying to do some wastewater testing, and we had
effective masks.
But
I didn't want to type. I wanted to engage her. But all these questions.
Oh, you're unmuted. Okay. What was it? Oh, so the wastewater folks in Austin, we really just begun to think about what that would look like, and they're in this interesting position where they have the technology to start testing the wastewater, and they've done it for the 2 large wastewater treatment plants in Austin, but they can't get funding to do more. And what they really like to do is to start doing more sampling, and UT is like, do more sampling, but we're not going to pay for it. So they're trying to find resources to do more of this. And what they want to be doing, and I'm sure I'm not using the language right, but instead of testing the big treatment plants where it's like half of Austin and you have no idea where you're seeing the signal from, they want to put it at specific manholes like outside the fraternity house or whatever it is to see if they can kind of get an early signal of cases, rising in those different neighborhoods or locations. And so I haven't really thought about how you incorporate that into the model, but we're starting to think about, just from their perspective, if they did have resources, you know, where would you want to budget those resources? You know, even if you get an early signal at a community wastewater treatment plant, and if it's for the whole city of Austin, what do you do about that, right? But so like, is there a way to get, if your goal is early detection, to kind of refine where you're like trying to sample, but maybe the goal shouldn't be early detection. Like a lot of the papers that have, or preprints I've seen have been about, if you monitor wastewater, you get 2 extra days. You get a 2-day lead time relative to when you see your first confirmed case. But maybe you want wastewater treatment if you can get a quantitative measure to tell you something about the progression, or I don't know. But I think there's a lot of potential there. I think we've just started to explore that. And I don't really know how we integrate that in our models, but that's an exciting possibility. Is there a plan to link an intervention with economic impact in your model? From Jagdish. That's a great question. And we would like to do more of that. And we, for example, and we have done some cost effectiveness analysis to try to kind of incorporate economics to some extent, where you translate infections into dollars somehow, or you translate isolating people into wages lost, right? And we try to do that. And when we do that, we get the expertise of health economists or economists, which we don't have that expertise directly. And unfortunately, in the consortium, we actually don't have an economist who attends regularly. So we go out, we look for folks. When we did the analysis that led to Austin's policy dashboard that I showed you, we didn't really know what to do at that point, because at that point, it was unclear what the costs of shutting down restaurants or, closing schools or all these things are. And it's still sort of unclear what that is, I think. But we certainly, in the race to provide something in real time that would allow Austin just to figure out what to do the next week, we didn't do any kind of thorough economic analysis. And in lieu of that, we just did this thing where we said, the goal is to minimize the time in lockdown. That was our proxy for reduce the economic and societal burden of the interventions. But I think that there is a lot of important work to be done to really think about kind of this from a more economic, social science perspective, kind of to integrate the epidemiology with all that. And I do think there are some groups that are starting to really make good headway on that. It's really an important direction.
So what do you want to talk about, Lauren?
I don't know. So, well, I'm curious about, I know I'm the man who left Ken, is that right? He said,
Kent Nelson.
Right. I am curious about how, you were able to navigate privacy and legal situation at University of Idaho. One of the things that has been particularly challenging is at the University of Texas is that the University of Texas, the folks that are kind of thinking through and leading the response efforts, they've made a lot of requests to us. They made a lot of requests to us to do analyses, to help them think through. And now that the kids are back and they're testing and they have clusters and they're investigating, they're not able to show us any of the data. So they're like, they're asking us to analyze, and yet there are so many restrictions in place to protect the privacy of the students that it's, I think, impeding UT's ability to kind of understand the situation and respond. And when they thought about like coming out with these symptom tracking apps and these contact tracing apps, they were very constrained by privacy. So we don't have one, right? We have one that is totally voluntary. And if you just, and you can erase your data any day you want. And so I think, yes, I'm just curious how Idaho has navigated that, and if you feel you've been more successful in making sure that Idaho's doing things safely and with full awareness.
We don't have tracking apps, but we tested all the students as they came back who were going to live on campus and who were going to attend classes in person. And they were very successful in doing those first tests. And they used the modeling to legally justify demanding that early testing. But we don't get detailed information about where cases are. We get sort of summary data, summary data are posted for the whole university every week. The number of tests they did, the number of tests that are positive. We are doing some sewage treatment assays, and some of those are at the level of buildings or groups of buildings.
And are they getting interesting information from those?
Well, we just shut down. I think they are using those to decide where to focus testing, where to focus voluntary surveillance testing.
That's interesting.
And so we just shut down 8 Greek houses, and I don't know how much of that was based on voluntary testing and how much of it was based on the sewage surveillance testing.
That's interesting. You know, I mean, if Idaho has data that can show that sewage surveillance, or that the localized sewage surveillance testing really was a good indicator of where to kind of focus surveillance efforts, that would help the folks at UT get, I think, some resources to ramp that up. Because right now, it's hard to get them to do it.
I think Thibault jumped off. He was on here before, but we can probably talk to them.
Yeah, and so the sewage testing is, there's sort of these ways of testing where you're taking a sample every hour, right? And you get this 24-hour conglomerate sample, and that's not what they're doing at these individual sites. At the individual sites, they're just grabbing a sample at the same time of the day.
That's interesting. That's great.
And so that's not ideal. And I don't have any faith that we can tell absolute numbers of people this way.
Yeah. But that's potentially really, though, interesting data and I don't know what the level of resolution of your models is, but I think, kind of asking the question back to Jennifer, I mean, do you see ways of incorporating, and I don't know if it's just presence absence data from these sewage tests, or if it's actually quantitative data, but of integrating that data that you have locally into your sort of models for situational awareness or projecting on campus?
Yeah, so it's not a data stream we're seeing yet in the modeling group, but I thought a little bit about how we might try to incorporate it. I mean, I think there's a couple things that are challenging. One is that you're going to continue to shed virus in your stool after you're no longer infectious. So it's going to pick up people that aren't transmitting anymore. So I think it's important to have sort of a constant signal. I think the signal for a town of our size, where we're only about 25,000 people in Moscow, like the central sewage plant actually, I think, could be useful. And definitely in the early detection, right? There's nothing here yet, but that would be good. But I think you could do some sort of a convolution and try to shift it a little bit. The question I have, and I think we'll have to just see how the wastewater goes up as transmission's going up this fall. Like we're having big spikes in transmission right now, and we might get some idea of what the signal to noise ratio is, because I think there'll be a lot of noise, right? It's just if that signal to noise ratio is sufficient, it could give us ideas about how much transmission we're actually having, more than what you get from case data, especially in a population that's so young and where we have a large fraction of our population who are unconvinced that COVID is something they need to be concerned about.
Yeah. It strikes me this whole thing with, testing. I don't know how long, I don't know if you know how long people shed in their stool beyond, their infectious period, but it's sort of reminiscent of the challenge we face with hospitalizations, where, some people are in the hospital up to 50 days and some people are in the hospital, 3 days. And when we're trying to fit the model to hospitalization data, we have to kind of consider that whole, range of what we're seeing when we're actually looking at the data. And so, it's not, I think it's not that different, but there's probably some other sampling to kind of embed on top of that.
One thing that I think could be really promising, if we had, like in Idaho and all of these rural communities, some surveillance, these tiny places that could really give us a, hey, now there's COVID here, even before you get a case. So I do think that for small communities, if we could get some sort of statewide wastewater surveillance system in place, it could really help make a difference in places where there's no hospitals. You know.
Yeah, and well, maybe I actually suggested to UT that they should do it. They should do it right outside the UT daycare. However, I think some of those diapers go in the garbage. I don't know if they go in the they go in the toilet, but I mean, I think that that's a place where there's going to be, a lot of asymptomatic before you actually, and hard to test little babies and things like that. It might be a good place where you're going to want an early signal. Yeah.
I think Bull wanted to ask you something.
Masks. So are you able to pull out an effect of masks from any of these models?
I haven't seen it. I mean, so we can't. I mean, what we are trying to do is something very coarse, which is, we have in our like mortality forecasts, we have really just two pieces of information. We have mortality and we have the mobility data. And what we see through time is kind of a decoupling of mobility and transmission that is presumably because people are being more cautious and wearing masks and doing other things to prevent transmission when they're going out in public. And so, the same level of going to restaurants back in March would have led to more transmission than going to restaurants now in some cities. And so at a very coarse level, we are trying to pull out, kind of regionally, how much decoupling is there as a proxy for what's the impact of things like face mask wearing and other precautionary measures. But we're not working at all specifically to really try to get in, into the weeds of can we pull out what masking is doing versus other measures. I haven't really seen much on this other than like some simulation studies, like some airflow simulation studies and some other, very kind of like indirect looks. But, it may be that with schools coming online, there may be more kind of data you can use to compare, situations where people are masking with not masking. But I don't know, it would be good to know, but we don't know. And I think that most people believe at this point that it's probably doing a lot of good and maybe the most good of anything we can do right now.
So Kent Nelson is back, our university attorney. So if you would like to ask him your question, your legal question.
Sure. Well, we started talking about it before you returned, Kent, but one thing that Holly just mentioned a second ago is that the models were used to help motivate the decision or justify the decision to require testing. And I'd love to hear a little bit more about what it was about the models or how they were presented or what, how that was leveraged to kind of get moved in the right way.
Yeah, so it was a very interesting process for us. We did the research and we approached it on a governmental fashion. The University of Idaho is a governmental entity, and so if we're going to require people to do something, we have to have an articulable basis to do so. And if we are going to do something as invasive as a COVID nasal swab test, and by the way, I've now done 3 of them. Then we needed a justifiable basis, and so rather than presume, we went back to the modelers and we had a meeting, and at the meeting we talked about what it is that the law requires us to show in order for government to mandate that somebody submit to what is really a constitutionally protected search. And that was a very good conversation. We talked about that articulable basis. We wanted and what the modeling could show us as to what would happen if we did this testing and were able to then take these steps in mitigation, and also to show us what would happen if we did not. And so fortunately for us, we had a president who said we were going to do this by the science. And so we did not have to do a lot of second guessing. Once again, however, we were looking for articulable science. So we relied heavily on CDC, especially at the outset, especially on things like the mitigation and the like. And then ultimately, Holly and company were able to put those models together that showed us levels of testing and the impacts on spread and hospitalization, and they started out, of course, recognizing that our plan was to bring all of our students onto campus, and so we would be bringing a whole host of people from all over the country, and they sat down and calculated, and they predicted a level of infection that would come to the campus, and they were almost spot on. As it turned out, we were able to conclude for the administration that if they chose, we could justify on a legal basis a complete screening testing of the students, and that's what we did. And we have been, knock on wood, relatively successful at maintaining our operations. Although we're currently looking at an issue right now, but I thought it was a very good teamwork between the modelers and the lawyers, who don't always necessarily agree with one another on how these things should go. So we were.
That's great.
So,
have you had to grapple with some of the same sports stuff and games that we've had to at UT, and how is Idaho handling that?
Yeah. So again, what's happening there is that we are pretty much at the mercy of the combination of NCAA and the leagues. So we're all in leagues, but then we still have to make our own decisions. And so we brought the screening testing on earlier for the athletes because they come to campus earlier. We actually had far better control over them because they all want to play their sport, and that's something we can take away. And so they did show up for testing far better, and they did a better job of quarantining themselves or isolating themselves depending upon the need and the like. And so we had positive tests. There's no doubt about that. But I think we were able to mitigate those relatively well. Now the question, for example, is are the leagues going to require the other schools to get tested, or does the university have to take its own position and make a stand and say we will not play a team that is not being tested and the like? So
yeah,
it's still a big challenge.
Yeah.
I've been watching University of Illinois after I learned of them and their testing mechanism, which is testing everybody twice a week, and whatnot. And just recently they were written up in the Times and I think the Wall Street Journal as well, because they had a spike. They had a spike around Labor Day, shock and amazement, students. But it looked to me like ultimately their system worked. The system isn't going to it can't guarantee you that the college kids aren't going to go out and do something stupid. I mean, I was a college kid. I did that stuff all the time. And so, but their testing mechanism, I think, identified it very quickly. They were able to put their mitigation into place. And so to me, that's the other thing besides the screening testing that we did that were justified is the importance of surveillance testing then going forward, because you have to know what's going on. You still have to be able to react to the situation. And so.
Yeah, absolutely. Yeah. And universities, I think, can have deep pockets maybe for testing everyone as much as they want. And with some of the smaller schools like the K-12, we're sort of running into, okay, if you don't yet have access to a lot of cheap tests, how much of the kind of things we're calculating now are, if you're able to test bi-weekly or once every 3 weeks, how big will the outbreak be by the time you catch it? There's sort of two different worlds we can be in. We can be in the world where we're going to be able to do enough testing that we're going to really kind of almost prevent it from getting in at all. Or we're going to be in a world where, we know we're not going to be able to do that, but we just want to kind of optimize it so that when we do have a cluster, A, we get it as early as we conceivably can, and B, we limit the collateral damage. And, then you get into the potting and the cohorting so that when you do have a cluster, it can only have gotten so far out there.
So I listened in on a couple of COGR sessions that I thought were also fascinating, and one that involved Yale and Oregon State, and they were describing their testing scenarios. And Yale, of course, has developed their spit test. Yale's project was to develop the cheapest test possible that appeared to have a reasonable degree of efficacy. And they're putting it on the open science market, and that's what University of Illinois kind of spun off of, although they ultimately developed their own test. Oregon State is massively involved in community testing in Oregon, if I understand correctly, and they are so they are out not only just dealing with what's going on in Corvallis, but really going out into the communities and helping with testing there. And I thought that was fascinating stuff too. The science, just listening to what Yale was doing and what Illinois were doing convinces me that we have no idea what the world's going to be like in February. I think the science is going to be, there's so much focus right now on the science side of this that we could have any number of amazing things or any number of bad news incidents between now and then.
Yeah, that's really interesting about Oregon State being proactive about getting involved in the community. I mean, one of the been a little bit disheartening is kind of the shunting of resources away from the city towards the university, to kind of deal with the threat.
And by the way, if you're feeling sad about how science is being treated in this whole thing, especially politically, understand that the U.S. Constitution is being treated equally as poorly.
No, it's challenging times.
Yep. So appreciate the opportunity to talk with you. I really enjoyed as much as I could listen to, and appreciate that all of you folks are sharing the way you're sharing. I mean, that's really the way the Academy should work.
Great, thank you. Yeah, it's been a privilege to be able to hang out with Holly and Jennifer daily. It was interesting, actually. I read this thing in CNN this morning. It was a quote, and it was like, in this quote, it was like, yeah, this is something everybody is saying. What was it? Everybody said, this is a well-worn quote. Oh my gosh, I'm not going to find it now. It was something like, we've lived, 5 years in the last 6 months or something like that. But it was said much better, and I hadn't heard it before, but I do think, and I think they meant that from maybe kind of a negative, perspective, the loss, so much loss in the last 6 months compared to, people having so many more people close to them die and get sick. But from a positive perspective, I think we've done more science in the last 6 months and, and really built bridges between science and policy and public health, in the last 6 months than we have in the preceding 5 years. So I think there's some silver linings.
Yeah, I certainly think, Kent, that the work that you and Barry and Holly and everyone did to get that testing done in the first couple of weeks of August did a great job of reducing the number of seed cases in our community. I think that's why we're only beginning to see spikes now, and I think it's super important for us. Yeah. So that was
and this truly was a community effort. I mean, we worked with our local hospital hand in glove. In fact, it's a very trusting relationship because I have still not been able to finish the contract with their lawyers yet. So, we're committed to this, and so that was a very good effort and makes a big difference. And now we're really doing this week, from my perspective, the first true surveillance testing, where we have selected a statistically valid grouping, and we've tested them, and just like jury duty, I found out that I was in it. So and hopefully we'll be able to extrapolate from the data then and make some choices that will be intelligent and help mitigate spread if it needs to be done.
Yeah.
So anybody have any last things that they want to talk about before we let Lauren go soothe her throat after talking for 2 solid hours?
I just want to say thank you for doing that. Was a fabulous presentation and a wonderful discussion, and I'm so glad that you agreed to do it. It was really wonderful.
Thank you very much. Really appreciate that. I did see there was one question from Eric in the chat, or a point that he was making about data availability and confidentiality, and the one slide I didn't really talk about was like differences between why is it so hard to forecast pandemics. So we did talk a little bit about, because you can't forecast human behavior, but the other thing that makes it so difficult is just complete lack of good data. And I think people who are not that in tune to what forecasting is and isn't I think they sort of may expect that forecasting pandemics should be like forecasting the hurricanes, right? And it's all these reasons why we know it's not. But one of the things is like, there's just been centuries and billions of dollars poured into developing forecasting machinery and data collection infrastructure, right? I don't know how many hundreds of thousands of weather stations that are all around the world, all around the United States, that are built and maintained just for the purpose of collecting data for these models. And so I think, part of it is it's just a different beast, but part of it is there's been really almost no development into building a robust data infrastructure or modeling infrastructure to do what we wish we could do better now.
Do you think we're going to be better prepared next time?
I mean, I do. I think yes, I do. I mean, I hope it's a long time till next time. It depends on how soon next time is. But I just think, I mean, it's so upsetting what's happened over the course of my career, where, avian flu got us a little worried, back in 1997. It kind of got the ball rolling with a lot of what we have been able to do. 2009 was like this sort of near miss that I think people just got so complacent after it. I mean, there was sort of a moment of, okay, what did we learn from that? And then, we could have leveraged that and really been so much better poised. And it's not just about the science. I mean, it really is about, the complete emaciation of our public health system. But, but I think, really building up a very strong science/public health preparedness resource, something we should have done after 2009 and we didn't. And in fact, I mentioned that work we did with the state of Texas afterwards. I mean, all those things we developed on the state's dime, they had like online tools, et cetera. When the person who was kind of the lead contractor, the person who sort of had the vision for that, when they left the state agency for a much better paying job, those things were shelved and forgotten, right? And community preparedness, the group got smaller and stuff like that. And so, but I think that this is such a wake up call. And I think people will really understand the severity of this and, the plausibility of something like this or worse happening. And that I can't imagine we won't invest more in it going forward.